Hello, everyone, and welcome to UNSHAME Kentucky's April webinar, Redefining Recovery. My name is Michelle Juma, Project Management Specialist at Shatterproof, and we have a fantastic 75-minute presentation for you today. I will get us started, but feel free to join us in the chat box by sharing your name, the organization you're with, and your location, and we can get everyone introduced to one another. To go over some housekeeping, this event is being recorded and will be available on the UNSHAME Kentucky website. All attendees will be muted throughout the session, and you can direct your questions to the Q&A panel at the bottom of your screen. You can also use the chat, but this won't be moderated as closely. For best audio quality, consider listening to the webinar via phone line by using the dial-in number or switch from computer audio to phone audio. Thank you. The UNSHAME Kentucky webinar series is brought to you in partnership with Kentucky Opioid Response Effort and Shatterproof. And I'd like to give a special thanks to the Office of Vocational Rehabilitation for providing ASL interpreting services for this event and all future webinars in the UNSHAME Kentucky campaign. For our agenda, we'll be moving straight into a quick overview of the campaign before we start our Redefining Recovery presentation and then panel discussion. Finally, we'll open up for question and answer and expect it to close at about 2:15 p.m. Eastern Time. I'd now like to introduce Marissa Williams, who is Program Coordinator of the UNSHAME Kentucky campaign, to provide a quick overview.
Thank you, Michelle. Thank you everyone for joining us today. As Michelle mentioned at the beginning, the UNSHAME Kentucky campaign is brought to you by Shatterproof, where I'm the program coordinator in partnership with the Kentucky Opioid Response Effort, or CORE. Just quickly for an overview here, we focus on an evidence-based approach when we have our UNSHAME campaigns. So starting with three main pillars, we're looking at community connection, sharing stories of people in recovery, friends and family of those that we may have lost to overdose, as well as some providers of recovery and treatment services. And then education, which we're here for. So community connection, we spent the first 3 to 4 months of our campaign connecting with over 40 organizations across the state to get a better understanding of exactly what addiction-related stigma looked like in Kentucky. We took that information to help drive our campaign forward. We also rely heavily on members of our Community Impact Committee. We have 8 members that will serve on our CIC. We just finalized interviews with those members. And the goal of the CIC is to really represent Kentuckians across the state and provide continuous feedback on the UNSHAME Kentucky initiatives. For story sharing, we've met with over 30 individuals that are interested in sharing their story with the campaign. We found that stories connect us to one another, and collecting stories really builds a bridge between those affected by OUD and people that may not have that personal connection. And finally, education. So we leverage the information found in our survey that I'll mention next, as well as information from our CBO partners to target priority populations via our social media channels, which is at UnshameKY on Facebook, Twitter, and Instagram. We also leverage the relationships that we have with CBOs and individuals across the state to spread anti-stigma messaging to their networks. So if you're interested in becoming a community partner organization or would be interested in sharing your story with the UNSHAME Kentucky campaign, there's going to be links at the end of this slide deck that'll be distributed that will be shared after the webinar. So please do that if you're interested. So talking about the survey a little bit, in order to ensure that our campaign is tailored to the needs of Kentuckians, we really need to understand the attitudes that people have towards those with opioid use disorder and the impact of the opioid crisis in communities across Kentucky. So this survey will be open until April 30th. Michelle's going to drop a link in the chat. I highly encourage you all to take that survey so we can tailor this as much as possible to Kentuckians across the state. So with that, I'm happy to announce the start of UNSHAME Kentucky's April webinar, Redefining Recovery, with our speaker, Dr. Jessica Johnson. So Dr. Jessica Johnson currently serves as a clinical pharmacist practitioner with the Robley Rex Medical Center located in Louisville, Kentucky. The bulk of her practice time is spent providing outpatient medication management services to patients at all stages of use and recovery from drugs and alcohol. In her role, she has increased the percentage of patients with alcohol use disorder who receive medication management, managed the implementation and ongoing services of SUBLOCADE clinic, and created harm reduction services and counseling for veterans who use drugs. Dr. Johnson is an advocate for the autonomy and patient-centered care of patients with substance use disorders and will be starting provision of PrEP for at-risk veterans from her outpatient clinic in August. In her non-clinical time, Dr. Johnson is a mom of 2 middle school boys, and she enjoys cycling in parks near her home in downtown Louisville. She also participates in annual Bike MS events to fundraise for the National Multiple Sclerosis Society. So with that, Dr. Johnson, I'll hand it over to you.
Thank you so much. I'm going to go ahead and try to share my screen. Oh, I'll ask Michelle to go ahead and let me share screen. Thank you. And we should be good to go. Can you all give me a heads up that you can see that? Is that showing, Lisa? Will you just wave at me if it is? Thank you. So I'm Jessica Johnson, and before we get started today, I like to remind people that while I'm employed by the Department of Veterans Affairs, my time here today and what I share with you it does not necessarily reflect the views of the Department of Veterans Affairs or the Secretary or the United States government. But I'm really excited to talk with you today and to share with these other incredible women that we'll have on the panel what recovery can look like and where we are now and why we might be wanting to change how we consider recovery and think about that so that we can make better impacts for our patients and our community members. And I think we often talk about medical journeys or other kinds of journeys as sort of this road. And so we're going to be using that analogy today and talking about what does traveling look like? We have to know where we are and where we're going. We have to know the steps that are in between that. We have to know barriers and facilitators, which is all applicable to how our community members and our patients and our family and friends approach their drug use and different methods of recovery. So thank you all for attending. I'm so happy to see the number of people that we have from a variety of spaces. So, in order to define where we're going, I'm planning a trip with my kids right now, and I have no idea where we're going to go. So we have not made the first step, but we do know where we are. And I do think it's important that we do some table setting so that we all kind of understand where we are on this map and on this road, because we can't really say how to get somewhere if we don't table set to come up with a beginning point. So we're going to look at some signs. And the first sign we often see when we talk about opioids is this big, like, kind of danger sign. You know, we'll see this on news reports. We have this opioid crisis, and it's very fear-based. We have a lot of attention that's paid to it. But one of the things that we don't really do is define it. We don't talk about how we know that it's a problem, how it impacts us. We certainly don't talk about what we think it would be to solve it. And so we need to know who it affects, how we know it's a problem, and what the objectives are that we're trying to reach. So I'd like to start there. And the very first sign that we tend to see is the one that we think of most commonly when we think about the negative effects of opioids in our community, and that's mortality and the people that we've lost. This has been a constant increase in our country from the early 2000s, particularly from 2019 to 2020. We saw an increase in overdose deaths in the United States by 30%. In Kentucky, that was even higher at 52%. So that's a 1.5 time jump from 2019 to 2020. In the interim, Kentucky has continued to increase 18% more. So if we look at 2019 and how many people died, it was a lot already. And since then, we've had a 76% increase. So these are people who are no longer part of our communities and our families. And we keep going the wrong direction despite a lot of the interventions that we've made thus far. Another thing that really informs how we've attacked this problem thus far and how it impacts our communities is the cost. If drug use and substance use disorders were a cabinet in the federal government, they would be the 4th largest one by budget. So we're behind defense and major things like that, but not much else. Based on 2018 cost, it cost us nearly $300 billion from drug use in the United States that year. That's from lowered productivity in the workforce, criminal justice costs, healthcare costs for drug use, drug overdose, and drug-associated infections, court costs, child care costs, things like that. It's more than the entire staffing budget for the federal government, for the entire system with which I work, for the VA, education, housing, and urban development. So it's a significant impact, not just on life, but on costs to our country and our community. And one last thing that I really want to highlight is that this problem, this crisis, has developed into a large amount of inequity with respect to incarceration. 2.7 million children in the United States are growing up in households where one or more parents are incarcerated. And when we look at numbers with respect to that, if we look at this first chart on the left, we see the United States population broken down by race. And so we know that most racial groups use drugs about the same amount. So we would expect our criminalization numbers to look very similar to our population numbers. Unfortunately, we incarcerate and enact those laws disproportionately on disadvantaged communities in the Black and Latino populations. What that ends up meaning is, aside from having children grow up in families without one or two parents at home, we're also creating a whole realm of downstream effects. So if we're thinking about how we want this to be better and how we want people to be engaged in society, when we develop incarceral policies that put someone into jail because of their drug use, we're then affecting their voting rights, their child custody, their employment abilities, their ability to get student aid, public housing, and other terms of assistance. So that activity and that way that we focus some of those efforts then really perpetuates a cycle in which it's very difficult for patients to recover meaningfully and contribute. So since we kind of know where we are, we're starting in Louisville, we're going on vacation, we're going on this journey, we have to know where we're going. And that's kind of the X marks the spot. And that means just, what does it mean for things to look better? How will we know when this is better? How will we know when we're improving? And that's very personal, and it's for us to decide, it's for our patients and our family members to decide, and it's for our community to decide. So we probably want fewer people dying. Most of us, I would say, would say that we want kids to be more involved with their own families, their families of origin. We want people engaged in contributing to their workforce, their community activities. We want less violent crime, and we want fewer infectious diseases or negative health outcomes because of drug use. So when we're talking about going on a journey and we're talking about where to go, the worst thing about a road trip is delays and road bumps and potholes. So let's talk about what some of those are, particularly for those in our community who use drugs and seek out our care as patients. And this one first concrete barrier that we run up against are some misconceptions and myths. And so I don't want to take a lot of time on these, but it is important that we're talking about the same things and that we're using the same language. There's a continuum of use for any substance. On one end, we have people who don't use at all, an abstinence. Then we have people who use, but not frequently enough to become dependent on it. And then we have people who are dependent or people who are dependent and suffering some negative consequences, which is what we usually call addiction or a substance use disorder. So I function best if I have coffee. I like coffee. I've grown very fond of lattes. I don't use them compulsively. I don't ignore my children to get them. I don't steal money to get them on a daily basis. But I do probably note that if I don't have one for a day or two, I'm going to have a headache. That's pretty consistent with dependence, not as consistent with an addiction or a use disorder. We have a lot of people in our community who are able to use drugs either at this drug use state where it's not building a dependence, or dependence without the negative consequences. So we need to be clear about what those are, because the interventions and the recommendations that we make for those patients are going to be different. Another really important thing that we need to make sure everybody is aware and communicating is that we have a narrative that is prevalent that you are able to overdose, especially from fentanyl right now, that by being in its presence, by touching it, by breathing near it, and that is scientifically and medically impossible. So the reason that's really important is because we need you to help. If we have somebody who has overdosed or who has kind of a weird looking powder on them, but clearly needs help, it is safe to help that person. You will not be able to ingest any drugs. Fentanyl doesn't cross a skin barrier without a pretty specific formulation from a patch. It also doesn't aerosolize, which means it doesn't become part of the air like COVID. And so that's really important, because then we as community members feel a bit more empowered to reach out and help our fellow community members. The last myth that I really want to challenge is this idea that someone has to hit rock bottom before they can really move forward. This is an incredibly dangerous idea. It does work for some people, but rock bottom isn't something that we can really define. Most people consider that they've hit rock bottom because then they're able to make some changes and have better and healthier use patterns. Rock bottom for a lot of people means death. And we are not able to help people who have already passed on. And so we want to be making these interventions early in someone's use pattern, along their use pattern, and help them to make safer and healthier decisions, even if they continue to use drugs, in order to have them be on a good pathway to healthier lifestyles. Regardless of how much you disagree with drug use, I think we would all agree that those patients don't deserve to have HIV or hepatitis or be unhoused. So we don't need somebody to hit their lowest point. We have lots of things that we can do for them in the interim. I do want to talk about stigma. So stigma bump ahead. Stigma comes from a lot of places, and it can be very challenging because this is a very difficult thing to treat. It can be difficult for the patient and the family and the healthcare providers, but I want to talk about how that impacts our actual person who's using drugs. The first place patients feel stigma is from themselves. I can't tell you the number of times, especially veterans, have this perception that they should be stronger, that they're better than this, that kind of thing, right? So I know better. I'm not trying hard enough. I'm weak. I should just be able to handle this on my own. Lots of self-hatred, lots of self-loathing about their use. So even if they're ready to quit or slow down, they have a very hard time asking for help because they don't consider that they deserve it. So that's one circle that impacts stigma. Then we have stigma from family and friends, which is understandable. Family and friends are the ones who are most negatively impacted outside of the person themselves, right? Sometimes those are the people who have had things stolen to support someone's drug habit, or they've had countless nights where they stay awake wondering where someone is. It's incredibly hard to be a family member of someone who uses drugs. However, we also have family members who don't have a background, and so they have ideas about what's the right way to move forward. They might have ideas about what is or isn't appropriate and right and wrong, and reasonable feelings of being burned out that then are put onto that patient in the middle. We get stigma from some recovered communities. We historically haven't had a lot of data on this. So a lot of it is just kind of finding your way as you go. And that means that a lot of people have an idea of one right path, right? Using a medication for opioid use disorder is cheating, or it's heroin light, or it's just an addiction to another substance. It needs to be 12 steps, trust in a higher power. You need counseling, you need to work harder. You need to just accept that you have no control over this. Lots of things work for different people. So if we have someone who finds themselves in a recovery community that doesn't fit with what's working for them, that can be a really stigmatizing experience. This one hurts me because it's us. We get a ton of stigma on our patients from healthcare providers. I have patients who are seen in the emergency room for something like a UTI, which has nothing to do with their drug or alcohol use, but everything's seen through the lens of drug and alcohol use. So I work with a harm reductionist in Philadelphia who this week needed to have neurosurgery for really, really dangerous and emergent pain condition. His wife took him to their normal hospital, wheeled through the door. The nurse said, "Does this person have a history of drug use?" The wife said, "Yes." The nurse said, "That's all I need to know," and wheeled him away. That is not okay. We deserve, our patients deserve the best care that we can offer. We need to treat everyone the same. We need to give them the best ideas and the best current evidence that we have to provide them with care. And we need to make sure that we're understanding that patients who use drugs also have pain, have diabetes, have COPD, and lots of those things are independent of their drug use. And then we have it coming from everywhere else too, right? So drugs are wrong. We have a moralism problem. It's criminalized. We have that inequity in how those laws are applied. There's a comedian called Mitch Hedberg who he has like short little clips. And one of the ones that stuck with me a long time ago was, you know, alcoholism is the only medical condition you can get in trouble for having. Like nobody says, "Damn it, Otto, you have lupus," right? So we have this idea that it's a moral failing, when really what we know is that brains are changing in response to use. And it's incredibly hard for some people who have different brains than others to get out of this cycle without a significant amount of help. So that leads to people feeling like they have to hide use or concerns or relapses, things like that. And then the last major pothole, like canyon-sized pothole, is we don't have a definition of recovery. Some people consider recovery to be complete abstinence from all substances. No coffee, no cigarettes, no heroin, no methamphetamine. Some people consider recovery to be, this is not controlling my life anymore, and so I feel like I am in recovery. SAMHSA, who we kind of look to for federal guidance, considers recovery to be this process of change through which individuals can improve their health and wellness, live a self-directed life, and strive to reach their full potential. None of that says anything about abstinence. Some people really prefer abstinence. Some people prefer moderate use. And so we need to start talking about the reasons that people use drugs, how we keep people safe, and which things will work best for that map in particular. Nobody's map looks the same. I've got patients who come in who quit drinking from a case of beer to nothing over 6 weeks. I have patients who go from one substance to another, or who are, you know, using marijuana once a month, but have had really bad problems with cocaine. So what helps everyone is slightly different, and what everyone needs is slightly different. And that has to be incorporated into how we fix things. That's why it's so important that we define the ultimate goal. Because if we're defining it just based on you're using or you're not, we're ignoring this whole raft of people in the middle. If we're going on a road trip, we have to have a map or Waze or guidebooks or some sort of idea of what's happening. I'm not going to fly to Juneau, Alaska and just be like, I might, but it's going to be a lot easier if we do it this way. So our first map and our first guide is harm reduction. Harm reduction does not mean that we say drug use is great, it's never going to cause you a problem, do what you like. Harm reduction recognizes that there are negative consequences, but it moves us into a sphere where we treat this more like we treat other things. My dad has diabetes. He's not going to be rejected from his physician because he had pie after Easter. So what it does is it recognizes that drug use is part of many people's lives, and that that's probably not going to change, and that our current interventions aren't working. So dropping pain prescriptions, reclassifying lots of new medications to be criminal penalties, those kinds of things appear to just be driving our overdose rate up. So we need a new model. And so what we do is we respect people and the choices that they make in their life and the things that are behind those choices. And we give them a say in what they're going to do and provide them with things that help keep them safe. So what does that look like? It looks like overdose prevention with naloxone training and education about that. It looks like syringe service programs. Last I checked, Kentucky had more syringe service programs than any state in the nation, which is like the first time we've ever been good, #1 in anything great. We should be very proud of that. That's a huge infectious disease protection effort and a great place for people who use drugs to find a community and find help. We should prescribe PrEP for HIV prevention. 1 pill once a day. If you came up in the 80s, you know what a big deal HIV was and how terrifying it was. The idea that we can prevent that to the extent of 99% or 75% for injection drug users is insanely effective and exciting. So we should make more use of that. Support groups, advocacy. We'll talk about medications for OUD in just a second. And housing and healthcare supports, right? If we're trying to change someone's whole approach to health and wellness, we have to make available those things that they may not have because of a criminal record. So what else works? And this is where I lose some people, but I want you to stay with me because it's very important. The number one intervention we can make for someone who has opioid use disorder is to prescribe buprenorphine, which you know is Suboxone, or methadone. Those are the 2 medications that have the widest body of evidence to prevent returns to use, prevent crime, prevent death, prevent all kinds of negative outcomes that we see. I know that's hard for people. I know there's an impression that it is being addicted to another medication, that it is cheating, all of these things. No, it is not cheating for somebody who has COPD to use an inhaler. It's not cheating for somebody who's diabetic to use insulin. It is not cheating for somebody who has Suboxone or methadone for their opioid use disorder. And we're going to talk about why that's important. So when we look at medications and what's effective and how we decide what's effective, we look at something called a number needed to treat. So I'm going to give you an example. Aspirin, one of the most commonly used medications in America. If you know somebody who's over 65 who's not on a blood thinner or aspirin, like very, very rare, right? How we measure its efficacy is we look at how many times do we have to recommend this and have a patient take it for us to prevent one bad thing. So if we're looking at aspirin to prevent a heart attack that doesn't kill someone, we have to give it to 77 people before we prevent that heart attack. But we do it all the time because it does that for 1 in 77 people. If we want to prevent a stroke that's not fatal, we have to give it to 200 people, or a death from a cardiac issue, 333. So very commonly used. I've used it forever. We consider this a very, very evidence-based medicine. The smaller that number, the better, right? If we could get it to like, I'm giving 1 in 5 people this antibiotic, or I'm giving this antibiotic to 5 people, 1 of them is going to save. That's really great. With buprenorphine and methadone, I give it to 2 people, 1 of them is going to stay in treatment long-term. I give it to 3 people, at least 1 person is still alive. That is an insanely efficacious medication. This saves 50% of overdose deaths. We're at 106,000 in 2021. We would have 50-something thousand if we had this available to everyone who's indicated for it. It is not cheating. It is an incredibly life-saving intervention. And so it's very, very important. And it's important whether or not someone agrees to counseling. Most people should have counseling. Most of us who don't use drugs should have counseling. But this holds whether or not they engage in psychosocial interventions. It holds whether or not they agree to do an extended residential rehabilitation stay. This medication is incredibly effective. And so that's the #1 thing we can do immediately, short term, to reverse this curve. So we know where we're going. We know where we started. We know what some of the barriers are. We know what some of the facilitators are. And now we're going to learn from some very, very smart people who are out on the road all the time. And I'm going to pass back off to Michelle to introduce those patients to you.
Thank you so much. Marissa, you could go ahead and begin introducing our panelists.
Yeah, absolutely. Thank you, Dr. Johnson. I'm really looking forward to this panel discussion to discuss some of those topics even more in depth. So our panelists today are Erin Cox, Shreeta Walden, and Dr. Teresa Walker. Erin Cox is a mother of 3 who has 4 years into her recovery and works for a nonprofit organization as a certified peer support specialist, helping others overcome substance use disorder. She is also working towards her bachelor's degree in social work so that with lived experience and education, she will be better able to help others who also struggle with SUD. Her goal is to save as many lives as possible and change the stigma surrounding all pathways of recovery, especially medication for opioid use disorder, which she says saved her. Shreeta Walden loves to introduce herself as an authentic, transparent, down-to-earth, and proud Black woman who loves family and connecting with humans. Between her hometown of Chicago and her current residence in Louisville, Kentucky, Shreeta is noted as an expert in the field of substance use and prevention. Her experience spans over 14 years, from working as a support technician in a non-medical detox to managing the operations of treatment programs for pregnant or parenting women. Her most recent endeavor of stepping into the role of executive director of Kentucky Harm Reduction Coalition allows her to focus on the current, most pressing needs of the people in her community who are disproportionately affected by substance use disorder, HIV, and Hep C. Dr. Teresa Walker is the owner and psychiatrist at New Leaf Clinic, a rehabilitative program for those struggling with substance use disorder and/or mental illness. The clinic's nonprofit, the Seeds of New Leaf, helps clients overcome their barriers to treatment, helping with transportation to the clinic, rent while in treatment, clothing, food, and other services. Dr. Walker attended the University of Kentucky for undergraduate and medical school and Western Psychiatric Institute and Clinic of UPMC for her psychiatric residency. She was born and raised in Louisville. Her father, Michael T. White, was 20 years into his recovery when he passed in 2016. So she grew up going to meetings and surrounded by the principles of recovery. This personal experience provides an empathetic lens through which she guides the clinic.
All right, I am so excited to have these women with us today, and it's been an absolute joy to learn from them as we started to plan this. So I actually want to start with Dr. Walden, and we've talked a little bit about the fact that everyone's math is different and that different things work for different people. What kind of experiences have you noticed, or how have you seen that different cultural and maybe even individual experiences affect a person's recovery pathway?
Hi, thank you. And thank you for your presentation. It was amazing. So at New Leaf Clinic, we see people coming from many different places. And a lot of times what pathway they take is determined by the rules of the organization that they're associated with. So we're kind of the hub, and we have, people here with all kinds of pathways, and we get to see the different ways of doing it. And our culture at New Leaf is that we accept all. And so there's no stigma or shame in one way that someone's doing things, but where they may be coming from might have their own traditional or old school approach to recovery, or some with, little accountability, or, so everybody does it differently. And what works for that person is what we encourage. And it just is not really a general statement that can be made. It's just, we follow what is working, and there's no judgment. There's no judgment in that. So here we treat medication for opioid use disorder, just like another medication. So we're not an MAT clinic. Everybody here isn't on MAT or MOUD. And it's just another medication. So when you come to see me, we talk and we see, oh, okay, is this a good fit for you or not? And so when you're seeing the doctor, no one knows, what medications you're getting. All we are thinking about and what we talk about in treatment team is, are you improving? Are you making progress? And are you seeing that life that makes this all worth it? So yeah, I don't know if that answers the question, but that's kind of my take on it.
Thanks. I think that's really, I love that approach. And I think it is so important that it's really directed and patient-centered. Director Walden, do you have thoughts on that as well, especially from your experience from the harm reduction side?
Absolutely. I agree with everything that Dr. Walker said. There are many different pathways that individuals can take. And then I know that a lot of people are like, wow, a licensed clinical alcohol and drug counselor is leading the efforts in harm reduction. Yeah, that's usually the response I get, because people are used to seeing people with my titles or certifications like certified alcohol and drug counselor as being primarily abstinence-based, focused treatment and recovery. What we have learned in our years of practicing as clinicians is that if we're going to be utilizing individualized care and focused truly on the person who is seeking this pathway, then we need to meet people where they are. And that is very abnormal to a lot of individuals who are actively working with individuals in abstinence-based programs. Meeting people where they are is walking into a situation where someone is still actively using a substance and finding out what is it that they need in this moment. What is it that is driving them to even have a desire at some point to want to stop doing something that is harming them? Even you notice my language is different than just saying, oh, this is substance use disorder. I'm saying that there is a substance being used and is causing harm to this individual and potentially the people around them and the community that surrounds those individuals. So we have definitely taken our lens and have put this approach of we're working with individuals to treat health issues that substance use has caused, if that was clear to everyone.
I love that framing. I think that's so important that we focus not on the substance being used, but on the outcomes, right? Is this affecting you negatively? And if so, how can we help mitigate that for you? I'm so encouraged by the work you guys do over at KHRC. Erin, as someone in recovery, can you talk a little bit about what questions do or should a person ask when exploring recovery options, both to themselves or a site that might help them? Like, how do they know which recovery pathway is best, if that's such a thing, for them?
Well, I think that just looking back on pathways that they've maybe tried in the past to see if any pathways in the past have been able to work for them. And of course, just it's something that you need to sit down and think about and really know the questions that you need to ask. Like, do you have any medical issues that medication might be a harmful tool for you to use, such as the mental health? Because the mental health is what led my struggle with opioid use disorder. So I've always struggled with depression and anxiety. So I had to sit down with my doctor, a therapist, and really determine whether or not the medication would be beneficial for me, which it has, but.
And then just curiously, like, what did that pathway look like for you? Had you made other attempts at recovery, and were there things that you found helped augment that path with medication?
Yeah, I had tried other pathways and, I wasn't successful at it. But doing the medication, the MOUD, it really helped me in a positive way is with my mental health and my recovery altogether. The medication has been very positive for me. And I know that might not be the case with everyone. And I no longer need to take medication for my anxiety and my depression. So I just take the buprenorphine. It's really helped me tremendously with my mental health. Using the MOUD along with other tools and working in recovery where I'm constantly educating myself, I've been able to overcome and live a life in remission from the opioid use disorder.
It's a strong thing that you do, and I know you do it every day. So I'm so grateful that you came to share with us today. Dr. Walker, Erin just brought up something that I think is an interesting point. We know that people use drugs for reasons often, and a lot of opioid users are often doubly diagnosed with the SUD, but also other mental health illnesses, like Erin mentioned, anxiety or depression. Are there things that you want individuals to be aware of when pursuing treatment, and particularly how might that affect their MOUD choices, if at all? And how else do you integrate that idea with other things?
Dr. Walker, you're on mute.
Okay, there we go. I was saying that it goes back to the story of that person and the evolution and getting to know them and their story and where they are right now, how we evolved to that point. And that really helps with interventions, as well as that history of what's worked and what's not worked. That goes into what choices we make, along with other medical conditions and medications that they're taking, liver function, things like that. Suboxone or buprenorphine itself, it's a partial mu receptor agonist. So it activates the opioid receptor up to a certain degree to help with the cravings and withdrawal and not cause intoxication. It also acts weakly on the kappa receptor for the opioid receptor, and that has these mild antidepressant effects. I don't rely on that to treat depression, but if someone doesn't endorse enough symptoms to meet criteria for major depressive disorder, they may get that added benefit out of using buprenorphine for opioid use disorder. They might also get that added mild antidepressant effect. But if there's someone with a major depressive disorder who is moderately to severely depressed, then I'm going to discuss all the factors that might be playing into that and consider a medication for depression if it's necessary in that situation. It's just going to depend on the person.
As a pharmacy nerd, I am so happy that you mentioned that kappa receptor, because I think that's a really undervalued and underappreciated point. Like you said, I wouldn't expect it to be the magic bullet for mood issues, but gosh, it is nice to know that it's way more likely to have a positive effect on mood than either the non-prescribed substances that they're using or other full opioids, because I think you're right. And Erin, what you're saying really bears that out. We do often see a lot of benefit from mood with buprenorphine too, which again is oftentimes contributory to the drug use itself. So thank you for appeasing the pharmacist nerds in the audience. I love that answer. Director Walden, let me ask you, so we have a lot of people on the call today, and from a variety of different backgrounds. So if we're talking with loved ones and community members particularly, what advice do you have for them in supporting individual people at different stages in recovery? What have you found is generally most helpful from the point of view of the population that you serve?
Great question. In our community, we are trying to create more spaces for families and friends. There are meetings to consider going to if you just want to understand a bit more about why your relationship to this individual is impacting you in such a personal way, which we call Al-Anon. Those are supportive meetings in the community. but we get it. We know that it can be difficult to watch a loved one who continues to use and you see the harm around them. We encourage folks to seek help themselves, being able to go talk to your own practitioner, a therapist, to talk about what's going on with you. We understand that substance use disorder impacts the entire family. At the end of the day, we continue to remind family members that there is nothing you personally can do as far as how to motivate someone to move on a different path. One thing that we do recommend with our organization is one of our partners, Louisville Recovery Community Connection, where we are housed, Kentucky Harm Reduction Coalition. We have lots of families that show up to our brick and mortar, the actual building right here on 3rd Street, and they receive naloxone training. Naloxone, for those that aren't familiar with naloxone, it is the overdose reversal medication that our organization actually distributes throughout Kentucky. We will train family members. We will train them on the spot. If they come down to our facility to get naloxone, I've had plenty of family members tell me it was because of the naloxone that they used on their child or their partner, and they were able to get to treatment when they finally decided that that's what they wanted to do, is go to a treatment program. Had they not used the naloxone, that family member wouldn't be here. So the first thing we like to do is equip our family members and our friends, or anyone that considered a part of their circle of love, our participants, equip them with the knowledge, with the education, and with the materials, which is the naloxone. We've also started giving family members fentanyl test strips. Some participants may not come to our mobile units where we're out in the different communities and set up to be able to provide harm reduction services to our participants. So we talk to our family members and those that are part of the circle of love about the importance of testing their products, their works. A lot of people don't understand that. A lot of people don't know that fentanyl is being found in almost everything that is out there. So even though a family member may say they're only using cocaine, or they're only using, they believe they're using heroin, or they're only using crack, what we found is that fentanyl is being found in all of those substances. So we are encouraging individuals to test it. The thing is, we can spend all day, because I know this is shocking to a lot of people. I don't want to negate what I'm talking about. It's shocking. We're talking about substance use. We're talking about people actively using. We cannot help a person if they're not alive. My new hire on my team, my new team player, began her journey 6 years ago at a mobile site where she was able to get a clean, unused syringe. She is now 2 years into her abstinence-based recovery program that she was able to choose to get into. Had she not stopped at a mobile site and received her materials that she needed, her safe use materials, had she not been getting tested regularly at these sites, she could have a different story right now, or we could be talking about in remembrance of. So the idea is that we are there to help the family see that no, we are not encouraging someone to use. We are encouraging them to be healthy for themselves and for their community being their family and the community that they live inside of. So I know that can be a hard pill to swallow. And those are the conversations that I have with family members that even come to our sites with their family, their loved one, for them to exchange their equipment and get wound care materials. I have that same conversation with them, that we need to keep individuals alive and healthy so that the day that they decide they want to take a different approach, we are right there with them. And we have more stories like my newest hire here. So that's how we're approaching families on this end. Same idea. We are working on another family group here in Louisville One of my volunteers will be starting that up, but it's a family group where people can come and communicate their frustrations, their concerns, and also gain a support system as they're navigating this world with their loved one.
I think that's really consistent with the principles of harm reduction, right? We aren't here to try to make it sound like there aren't negative consequences of drug use. There are, obviously. But like you said, we're trying to help recognize those, help remind people that even because somebody's using drugs, it doesn't mean that they deserve HIV, endocarditis, right? And so helping family members kind of accept that and work toward that is so great. Erin, I did want to hear from you. You talked a little bit about what long-term recovery on MOUD looks like for you. What kind of barriers do you see? We talked about some. Are there others that you see that really affect people's recovery? And can you tell us some stories about how those have impacted people or how they've overcome them?
Yeah, so transportation, housing, two biggest barriers that I'm seeing. I do have one participant who, when I first got with her, she wasn't really doing anything. She was just kind of there in a homeless shelter. Since I've started working with her, she now has a job. She's setting goals. She's meeting those goals. She's received 2 raises at her job. She's working on getting a promotion, and she's doing everything that she needs to be doing. So housing and transportation would be the 2 biggest barriers that I see, though.
And then to our other panelists too, are there barriers that you've helped someone overcome, or things that you think still really throw up difficulties for our patients as they're going through systems and kind of trying to figure out the right path for them?
I can speak to that. So that's the whole reason that the Seeds of New Leaf was founded, because we have this great therapy, we have all of these therapists, psychiatrists, case manager, but if they can't get to it and they can't access it, it doesn't matter. And so that was the whole point of the nonprofit, to help them overcome those barriers. And the barriers that we've seen through this process, the first one is an ID or insurance. So if they're coming off the street, or they're coming from jail, or just out of active addiction, it's hard to keep up with these documents. It's hard to keep up with the list of things you need to get these documents. And it's hard to come up with $10, $12 that it takes to go and get it. And so helping them get an ID, number one, you got to get there. How are you going to get there? How are you going to pay for it? Do you have the documents that you need once you get there? So that's one thing that we help with, is assigning a peer support that can take them, pay for it. It's a big deal. It's a game changer. And for somebody that is on, maybe a little irritable, coming out of withdrawal, doing the best they can to function that day, that one more thing just might, like, oh gosh, I had everything, and it just might be the thing that just causes them to give up for that moment. So that's insurance, ID, transportation, of course, just like Erin said, is a big one. So providing that ride, but also at the same time, what we do is teach them their natural resources while they're here, because they won't be, in our program forever on using the New Leaf van. So we teach them about the resources they have in their community, like federated transportation, their insurance might provide it, teaching them how to use the bus system. I think that's a way to overcome that barrier. I'm going a step further with this question, and then housing. So they're coming out of the hospital, jail, the street, and you want to get into sober living, because where you live at, there's people using drugs all the time. And so to give yourself the best chance, you try to get into a structured environment where there's no use going on around you. And so you're not triggered, but you need a deposit in your first week's rent. And where are you supposed to get that at? So I actually discovered that barrier when I was the psychiatrist at the jail. And I was working with Monet at the jail. And she was like, when your dad was here, he used to let, them come in for the first week without any rent. Well, once he passed, then it was more going by the book than anything else. And so I was like, okay, I've got to do something about this. What are people supposed to do? So that's a big one. Food, hygiene products, court. is so stressful and anxiety provoking, and there's so much out of their control that they just sometimes want to give up, and they don't have the resources to fight it. So it can strip hope. So family and old ties is a really big one. Like feeling like they're leaving someone behind that is not, on the same path that they are. I mean, I could talk a lot about barriers to recovery. There's so many, and yeah. So that's our mission, is to overcome that.
Okay, we have about 5 minutes left before we start taking audience questions. So I do, this can be overwhelming. It can be a lot of information. I'd love for each of our 3 panelists to, if you have one biggest point take home message today for either someone who uses drugs, as a family or friend of someone who does, who is a healthcare professional or in criminal justice, what's your one big take home that you would really want somebody to take away from this today? Let's hear from Erin first.
Yeah, so it's for me, it's about saving lives, and MOUD is a pathway to recovery.
What about Dr. Walker?
Look at how someone is doing. What are the goals for this person? If they're doing well, then cut out all of the other noise. Let's look at how they're functioning, and if they are living the life that they define as a life worth living, and stop all the opinions and judgment and just help them along that path.
Cut out the noise. I love it. All right, Director Walden, what's your one take home?
I know that these can be difficult conversations when we're talking about use of substance, especially illicit substance. I value my colleagues, and I always say, allow the people who know this work to do the work. You as a family member, you as a professional in another field, in another lane, do not have to have the conversations that we have, do not have to discuss the ways of harm reduction. Allow us to do that part. Allow us to speak to the individuals. If you're frustrated, allow them to connect. We will provide the resources. We will do the work. Connect them to us. Allow us to be that conversation piece.
Outsourcing makes a lot of sense. I've never thought about it that way, right? Okay, so Michelle is going to be moderating some questions for us and sending them my way. I think the first one that I have, and this can be any of the 3 of you, or I'm happy to talk about it too. Seth Steele has asked for recommendations for getting Suboxone or MOUD services to more rural and remote counties. That's a great question for Kentucky. Do any of our panelists have thoughts or ideas about that? I'm happy to jump in if nobody else has thoughts on that. So I think one of the biggest things that we have right now that's an advantage is that for now, due to the public health emergency and a couple of other things, training requirements are waived for X waivers. So in order to be able to prescribe Suboxone or buprenorphine, physicians, nurse practitioners, PAs are required to have something called an X waiver, which is an additional part of a DEA license. Historically, in order to do that, physicians had to undertake 8 hours of continuing education specific to that. And then nurse practitioners and PAs had to take 24. It was a lot. And so right now, people can obtain an X waiver if they have a DEA waiver without that educational requirement for treating up to 30 patients at a time. So that is a huge, huge flexibility for us. So what we really need to do as a state and within communities is encourage some more practitioners and providers to obtain that X waiver. And right now that education barrier is gone if they can treat up to 30 patients. So that's a huge, that's a good question, Katie. So Katie says the waiver of training isn't applicable in Kentucky because of KBML regulations. So I'll go ahead and look at that, but that has been my understanding, is that that was eligible. So we'll get clarification on that and maybe send out a confirmation. Regardless, we need more ex-waiver trained physicians or nurse practitioners or PAs, or we need to eliminate the ex-waiver entirely. Buprenorphine is an incredibly safe medication. It is almost impossible for an adult to overdose on buprenorphine alone. It is dangerous for children, so we have to be careful with that, but there are no requirements for doing 8 to 24 hours of continuing education for something like oxycodone prescribing. And so really, if we're going to approach that, it's very, very helpful if we have more flexibility with telehealth and also with things like eliminating that ex-waiver barrier. So I would encourage providers in your area to go ahead and get that ex-waiver. There are lots of support systems online, especially PCSS Now, which I'll put in the chat, that does allow people to call in and ask for expert advice if they're not as comfortable with how to initiate and things like that. So absolutely, rurality is a very difficult spot right now. We're having a hard time with that. Looking at some of the other questions. So Fred had asked about a patient using MOUD who has chronic pain, which limits her functioning, and wants to discontinue MOUD to seek pain management. I think we talked a little bit about that in the chat. There's some dose optimization that we can do with buprenorphine sometimes, or methadone is a great pain reliever. I think the naloxone training question was answered. I'll talk to Beth Workman offline. Really, really, really love Wisconsin. It's in the background of my photo. So thanks to the Wisconsin project coordinator. I think there's some conversation going on in the chat about deaf and hard of hearing access for groups. Let's see, what else do we have? How do support groups accept interpreters in their meeting? I'm happy to leave that open for anyone to ask or answer. Michelle, other thoughts?
I'll quickly just jump in. Recently added to the chat was the website for the Department of Deaf and Hard of Hearing. Michelle Niehaus has become an excellent partner of the campaign and may be able to offer a little bit more information about getting interpreters to support your work. But yes, the link has been added to the chat box.
And this is Shreeta speaking. I believe that Thomas Spicer responded, groups accept interpreters as they are an extension of the person attending the meeting. Thank you, Thomas.
I do have a question from Fred Mills that says, any concerns with using buprenorphine and gabapentin or pregabalin together? Dr. Walker, what are your thoughts on that?
Could you repeat that? I'm sorry.
We have a question about whether or not there are any concerns with using buprenorphine, Suboxone with either gabapentin or pregabalin. How do you handle that in your practice?
We have to do what we have to do to get your pain treated. And there's not any significant interactions with that. You know, those act on the GABA receptor and these act on the opioid receptor. And we basically monitor clinically to see how you respond to each medication and monitor from there. It's all about risk-benefit discussion. So we've got to treat your pain with that because that's the risk of relapse in itself. And so we only have so many options, and so we have to just do a risk-benefit discussion about all of the options and what's going to be the one that has the most benefit outweigh the risk.
Yeah, I tend to agree. I often try to remind our team here when we're looking at relative risk and benefit of medications, often our analysis sometimes we'll think as healthcare providers is, if I add this on, does this make it riskier? And often, yes. So if we're doing Suboxone and somebody needs a benzodiazepine for something, on the surface, that does sound incredibly risky. But we aren't just evaluating a benzodiazepine with Suboxone. The other side of that risk equation is probably a benzodiazepine with contaminated fentanyl that we have no control over the purity, we have no control over the other contaminants and things like that. So I agree. My priority is initiate what we need to initiate and monitor carefully, but that Compared to full opioid agonists, I have way fewer concerns about buprenorphine as a safe medication, especially with respect to things like overdose and respiratory depression. Michelle, you gotta give me a heads up if we, oh, okay. We have another one from Marlena Carpenter. A huge barrier we see in our area is that the clinics will only accept certain types of Medicaid for the services provided. And then when a client has chosen a company outside of open enrollment, it's very difficult to get things changed for that patient. Any thoughts on that from anyone on the panel, especially anyone who might deal with a lot of Medicaid issues and helping navigate those insurances?
I'm not sure. Medicaid, maybe it depends on the level of care or what service codes they're using. Because for us, all of Medicaid pays all Medicaid payers pay what we provide. Maybe there may be some commercial insurances that won't do it. And you know what the big one is, the high deductibles for people. And there's no great answer. My fight is to find funding through the nonprofit that can help people overcome those type of barriers. So, or maybe finding a clinic that does take, it's a real problem for people when it comes to insurance. That is the point of the nonprofit, to help with that kind of stuff when it doesn't fit into that perfect little box when it comes to insurances, because when somebody's reaching out for help, like they've made that decision, we need to act. So it is hard and it is a balance. But I don't know what that situation is where different Medicaid payers pay for different stuff. I'm not aware of that.
And my understanding, and maybe someone can correct us in the chat if I'm wrong, but my understanding is that in the state of Kentucky, it is now required that Medicaid cover all 3 medications for opioid use disorder without PA and without preference. So if somebody can verify that in the chat, again, I work for the VA, so I'm blessedly immune to many insurance issues, but okay, thanks, Katie. Yeah, so I would say, especially Michelle, if you're having specific issues with that, I would think the Medicaid Service Office at the cabinet might be interested to hear about that.
I'm not seeing any additional questions coming in through the Q&A feature, but if folks have any other questions, please feel free to submit them before we move on to our resources. All right, so I'd like to thank our panelists and Dr. Johnson so much for leading that discussion. I'd now like to just share some resources for our attendees that would be helpful tools to go back to their own communities with today. The first being visiting the Find Help Now website for up-to-date and accurate information about treatment offerings available in your area. As well as some core sponsored pieces, including a recovery community center's infographic going over different support services and offering. The Kentucky Access to Recovery infographic is also focused on removing barriers to the services and supports needed to achieve and sustain long-term remission and recovery. The Kentucky Recovery Housing Network is brought from the Cabinet for Health and Family Services and is a state resource for recovery residence providers seeking standards, protocols for ethical practice, training, and state-of-the-art information pertaining to all levels of residential support. Founded by one of our featured panelists is the New Leaf Clinic. This is a focus on providing treatment for the whole person with several service offerings available in office. The nonprofit Seeds of New Life has championed 2 particular programs. The first being Treatment First, which is about supporting fully engaged clients with housing assistance at approved sober living facilities. and also the Recover Boldly campaign to decrease the stigma of substance use disorder treatment and increase access to treatment and resources for the Black, Indigenous, and person of color communities across Kentucky. From the Kentucky Harm Reduction Coalition, we also have several naloxone distribution and training programs. Please visit the website for more information about how you can better support their commitment to reducing overdoses, overdose deaths, and the transmission of bloodborne diseases. And finally, from the Shatterproof team, I'd like to share that registration is now available for the Shatterproof Stigma of Addiction Summit on June 8th, 2022. This is a free half-day event virtually focused on understanding, addressing, and eliminating the harmful impacts of stigma on those who experience addiction. And for those interested in continuing on this UNSHAME Kentucky webinar series journey, we have next month's event ready to go. It is going to be How Harm Reduction Helps. We've invited Jennifer Twyman of Louisville Metro's Public Health and Wellness Harm Reduction Program to speak to us about current efforts in Kentucky focused on harm reduction, some of the limitations of those programs, and what opportunities are available to improve them, examples of really successful studies, and we'll be open to answering any questions that you may have. I'm seeing folks including their emails in the chat, and I'm so glad that you all are so willing to use this as a resource. We hope to continue to put on these webinar series that will allow us to spread this information and facilitate more of these conversations. As you close the event today, you will see a post-event survey. Please consider completing it, as well as indicating within the survey if you need a certificate of attendance. Okay, so I will put together a PDF and email out copies of the PowerPoint slide, and links will be available for those to follow up with. But thank you so much and have a fantastic day.